So firstly, I thought we'd go through by defining what pharmacokinetics is. So pharmacokinetics is essentially considering what the body does to the drug that you're taking in, whereas pharmacodynamics is what the drug is doing to the body in very simplistic terms. And then in terms of the drug, it's any sort of chemical agent that is taken into the body that affects the processes of living. And then drugs often act on receptors. So a receptor is a signal transducing protein which changes its shape, so its conformation upon the agonist, which is the drug binding, but it does not change the agonist itself. And lastly, half-life is the time taken for the drug concentration to essentially half from its original value. And this is determined by two other phrases that we'll look into further, called the volume of distribution and the clearance. So in terms of these definitions, they're quite good to know for MCQs and stuff, but also if you choose to write an essay on it at the beginning, it's quite good to define what you mean by these things before you explore things further. So in terms of pharmacokinetics and drug action, I'm sure you guys have come across the concept of ADME, which is sort of how we like to break down drug interactions within the body. So the A in ADME stands for absorption. So does anyone have any sort of ideas as to what determines the absorption of a drug within the body? Feel free to message or just shout out. Okay, so in terms of absorption, a few things affect how a drug is absorbed, including its chemical nature, the route we choose to administer it through, and the formulation of it. So if we look at the chemical nature further, a few things determine it. So the charge, the transporters and channels which are available, its lipophilicity and its size. So I've looked into the charge a little bit more just because this comes up on MCQs, which is basically in the context of local anesthetics, which are weak bases which then act on intracellular channels, but they cross the plasma in their unionized form. So where this comes in terms of medicine and a consideration we need to have is that local inflammation decreases the tissue pH, which means there's obviously a higher H+ concentration, which shifts the equilibrium of the ionized form. Which often means in these periods of local inflammation, local anesthesia can be delayed or even prevented. So this is a point of consideration sort of later on down the line in terms of clinical medicine. And then the other chemical factors, as we've said, is the numbers of transporters and channels which then mediate the uptake. And this can vary by organ and tissue and things like that. And then it's how lipophilic something is, so that's in relation to the fatty acids, and also the size of the drug molecule, all of which determine absorption. And then the route of administration, which is what you'll sort of come across day to day as a doctor. So there's several different routes that drugs can be administered through, and certain drugs can be administered in different ways depending on sort of the effect that you want to have with them. So you can have oral, buccal, which is sort of within the tongue mucosa, sublingual, rectal, IV, so that's into the veins, IM into the muscles, subcuts, so under the skin, and also some can be inhaled, especially if you're trying to get right to the lungs. So all of these different methods have different pros and cons to them. So I'll sort of look through the more common ones. So can anyone think of anything that is good about IV, why you would want to give a drug IV?
Fast acting.
Yeah, really good. And anything else about a drug that means it must be IV? So another reason it's quite good for drugs with a narrow therapeutic window, because you can often get quite an accurate concentration. And then subcut and IM act faster than oral drugs do, and they can often be given in depot form. So depot is sort of when you inject it and it stays under the skin for a while, and this is quite good for in instances where people have poorer compliance, and also mean the person doesn't have to regularly come and take the drug. So certain contraceptives given in depot form as well. And between IM and subcut, IM absorption is faster because blood flow to the muscle is higher than it is to the skin. So I suppose if we just think of it logically. And I'm sure, as you guys know, oral is the most common way of administering a drug, and this relies on passive perfusion. And most medications are actually absorbed in the small intestine, and for most, except in terms of the course, the one you need to remember is tetracycline. And a certain number are also absorbed via transporters themselves. An example of that would be a drug like levodopa, which is used in Parkinson's. An important point to note is that the acid in the stomach that these drugs have to pass through can degrade some drugs, which is why certain drugs have this enteric coating, which essentially prevents this and allows the drug to transport into the small intestine. So at this point, I'll look into the first pass effect, but we look into that a bit later in metabolism as well. So basically, this is when the drug is absorbed through the gut epithelium and then travels through the portal circulation into the liver, so that direct connection. And this is where many drugs are metabolized by enzymes in either the small intestinal wall or the liver. And this is what they refer to when they mention first pass metabolism, but we will look into it a bit further later on. And in terms of rectal and sublingual methods, they avoid the stomach. And therein they then avoid this first pass metabolism, which is why I mentioned it. Lastly, a thing to consider is bioavailability. So that's the fraction of the delivered dose that we give that actually reaches the systemic circulation. And a lot of different things can determine bioavailability. A few include how well it crosses the gut epithelium into the lumen, the metabolism of the drug, any interactions it has, and also gastric motility itself can control this, so how fast things travel down the tract. So the next is in ADME is D, which is for distribution. So does anyone feel comfortable describing what they understand distribution to be? Okay, if not, so distribution is sort of how drugs equilibrate within the body after they enter the systemic circulation. And there's a lot of different factors that determine how this distribution comes about, with some drugs having almost no distribution, the barriers that these drugs have to cross, whether they accumulate in certain tissues, and again, lipophilicity. So in terms of exploring the barriers, some examples of barriers drugs often have to cross is the endothelium of blood vessels, the blood-brain barrier, and placenta. And both the blood-brain barrier and placenta are important to remember in certain groups of patients. So in terms of the blood-brain barrier, it essentially is quite the type, I'm sure you guys know, a type barrier in the brain. And the barrier function of this changes in the case of meningitis, which is where you can use certain and not others. And similarly, whether a drug can go through the placenta affects whether a drug is safe to take in pregnancy or not. So this is a factor that we consider. So in terms of the endothelium, so that separates the plasma from the interstitia, and it's a single layer, and it allows most polar small molecules through. But an important drug to remember that it doesn't allow through is heparin. And then, as we said, the blood-brain barrier is this tight junction between endothelial cells surrounded by astrocytes, and it's essentially impermeable to most drugs unless they're sufficiently lipophilic. And as I said, they're disrupted in infection, and that's what allows antibiotics through in meningitis. And lastly, the placenta, as you mentioned, is an important thing to consider in pregnancy, and small lipophilic molecules can pass through by passive diffusion, but hydrophilic molecules need a specific transporter. So the example that they bring up in first year is thalidomide, which did manage to get through and is what led to the abnormalities that presented when mums took them when they were pregnant. So, and then the next thing to consider is the fact that the blood plasma concentration of a drug is not always the full picture. So drugs distribute differently in certain tissues like the brain versus the fat, for example, which also means that the volume of distribution, which we will consider next, immediately after you give a drug through the IV method, might be much lower than the apparent volume of distribution. And this is something you need to consider in the models that you look into. But I don't think we need to go into that level of detail now, but it's just good to have an awareness of it. So the volume of distribution, which is mentioned, is the amount of a drug over the concentration of said drug in plasma. And it's essentially how much of the drug is sort of no longer in the bloodstream. And it's quite high for lipid-soluble drugs and quite low for water-soluble drugs. So heparin, as you mentioned, has a volume of distribution which is very similar to the plasma volume, which often is because it's largely restricted to the plasma compartment. As we mentioned, it can't cross the endothelium, whereas ethanol has a volume of distribution which is very similar to the total body water. And this is because it's spreads throughout the body compartments, and it can bind to tissue, plasma and protein, and things like that. An important thing to remember in terms of lipophilic drugs is their partitioning in fat, which means that a greater amount of the drug is accommodated within a lower plasma concentration, which then goes on to affect the volume of its distribution. In terms of plasma binding, the most important thing you need to remember is the plasma binding proteins, the most famous or common one of which is albumin, and it acts as a site for acidic, neutral, and basic drugs. The main thing in terms of medicine that we need to know about it for is the fact that albumin levels fall in liver disease, in older patients, in kidney disease, and if someone's had major burns, which is why certain drug doses have to be adjusted in these populations. And in a similar vein, some drugs saturate albumin in their therapeutic range. So phenytoin, which is an anti-epileptic, saturates albumin at the level it needs to be given at. So it's important to consider this when dosing someone up. Okay, so the next section, where I'm sorry for rattling through, it's just we've started late, but feel free to stop me anytime. The next section is M for metabolism. So that is essentially the breakdown of a drug. So can anyone think why we would want to metabolize a drug and not just excrete it? Yeah, you do want temporary action of certain drugs, definitely. Yeah, definitely prodrug into active form is a way lots of drugs act. Great, so yeah, great answers, guys, and you're all correct. And you also often, in terms of excretion, want to modify the drug so that it's more polar, so it passes easily into the renal tubule, and also try to avoid it diffusing back through the nephron wall if it's a lipophilic drug. But well done. So first pass metabolism, we went through this a little bit, is essentially the metabolization and inactivation of a drug before it reaches the systemic circulation. And it occurs in the gut wall and the liver, especially in the examples of drugs like propranolol, verapamil, morphine, nitrates, which you come across, I'm sure, in first year. So in terms of the pathways of drug metabolization and elimination, Some drugs are excreted unfazed by the kidneys, like furosemide, the diuretic. But some also undergo this phase 1, phase 2 metabolism, as outlined here, and that's most drugs that you come across. So phase 1 metabolism is essentially the creation of reactive polar functional groups. It's essentially a functionalization of the drug. It's often catabolic reactions, and yeah, they make a more reactive metabolite. So different reactions occur, but more commonly it's oxidation, usually by the cytochrome P450 system, reduction and hydrolysis, and one of you correctly mentioned it's the prodrug forms happen within phase 1, but some drugs don't require phase 1 because it's just how the body works. And then phase 2 metabolism is the production of polar compounds, which are ready for renal elimination. And this can be either of the drug itself or in cases, or its phase 1 metabolite, depending on whether it underwent phase 1 or not. And these reactions are anabolic, and they tend to be conjugation reactions, and essentially make a less reactive metabolite. So this would include like glucuronidation, sulfonation, acetylation, and methylation. And they essentially increase the water solubility of the drug to allow excretion. So in terms of metabolism, one of the main things we want to focus on is, as in it's applicable to medicine, is the cytochrome P450 system. And it's the most important system of phase 1 metabolism. And there are over 11 different subtypes of cytochrome P450. So there are 2 subtypes that I've looked into further, just because they're the ones that a higher number of proportion of drugs are metabolized by. So CYP3A4 is the most important because over 30% of drugs are metabolized by it, including calcium channel blockers, beta blockers, statins, and benzos, so a lot of your heart drugs. And then the other version is cytochrome P2D6, which is the second most important, and 20% of drugs, including antidepressants and opiates, undergo this system. The reason that we learn about cytochrome P450 is certain drugs can act as inducers, inhibitors, or obviously rely on this drug. So the drugs I mentioned above rely, so not on this drug, so rely on this enzyme. So drugs which induce this enzyme, such as phenytoin, barbiturates, and alcohol, will affect the metabolism of these drugs. And in a similar way, inhibitors such as valproate, so that's an anti-epileptic, and ciprofloxacin, which is an antibiotic, omeprazole, and things like that, will inhibit cytochrome P450, so again affect the metabolism of drugs that rely on cytochrome P450. And one of your colleagues mentioned prodrugs. So examples of certain prodrugs include L-DOPA, which is converted to dopamine, and enalapril, which is converted to enalaprilat. I know this is a lot of information, and I feel drug action and pharmacokinetics is quite dry, but there are notes at the bottom of my slides, so please don't feel that you have to memorize this or write it down. It's there in greater detail for you to explore later, and if you have any questions, feel free to ask. And then the last stage of ADME is E for excretion, which I'm sure you guys know. So which form of excretion is the most heavily utilized? Yeah, renal, perfect. So as you said, kidneys are the principal site for excreting the water-soluble molecules, and drugs can be excreted either by being passively filtered from the plasma and then or secreted into the renal tubules. They can also be reabsorbed from the tubules, and if they're polar and not heavily bound to plasma protein, then they're readily cleared by the glomerular filtrate, such as aminoglycosides. So this is important to consider in terms of the excretion rate of certain drugs. Secretion of drugs from the plasma to the lumen occurs through two transporter families of the SLC transporters, and they are OAPs, which transport acidic drugs in their negatively charged forms. So an example to use for that is paracetamol, or OCTs, which transport bases in their protonated cationic form. So an example to use for that is morphine. And these conjugated metabolites are more water soluble, so they are more freely filtered. But conjugated metabolites can also be secreted by one of the SET channels, the OAT, the acidic channel. But since they're more polar than the parent drug that they were derived from, they're less likely to be reabsorbed from the tubule. So that's a lot of information, but the main thing to remember is you get passive filtration and secretion, but some forms can be reabsorbed back. And the channels that are involved in the secretion are the SLC transporters, and that's one for acidic forms and one for basic forms. Then a less common but still prevalent method of excretion is through the biliary system. So this is where liver cells secrete drugs and their metabolites from the plasma into the bile using very similar transporters to the ones that we see in the renal tubules. And then this bile goes into the small intestine and it's excreted in the feces. Unmodified drugs can be reabsorbed and conjugates can be hydrolyzed, which will potentially regenerate an active drugs. An example of a form that's particularly susceptible to hydrolysis is our glucuronides, and then the hydrolyzed drug can then either be excreted in the feces or reabsorbed. And if it's reabsorbed, then this is called enterohepatic circulation, which then goes on to slow the rate of elimination of a drug from the plasma, which prolongs the effect of the drug. So it's just important to remember that this form of reabsorption exists, and we need to account for it in our models in terms of predicting the clearance of a drug. So in terms of other methods of excretion, some drugs are excreted through the sweat and also through breast milk. Sorry, that's a typo there. And this is important to remember for mothers who are breastfeeding, because if certain drugs are excreted in the breast milk, they might be contraindicated during the lactation period. So clearance of a drug is a volume of plasma that is cleared of the drug per unit time, and that's just another definition that is good to remember, and goes on to affect their half-life alongside the volume of distribution. So sort of nearing the end now, in terms of a lot of pharmacokinetics, we rely on these mathematical models which essentially predict for us how drug concentrations vary over time. And they're used by us and clinicians and whoever to predict what might be an appropriate dose to administer to a patient. But they often assume that drug eliminations follows linear kinetics, or also known as first order kinetics, which essentially means that the rate of elimination is essentially directly proportional to the plasma concentration. And this is true for many drugs, and renal filtration is also not enzyme dependent, so it can't be saturated. So this also holds true. But and this essentially means that we imagine if we intravenously inject a single bolus dose of drug and then measure the plasma concentration at various times, and then we use that as a good predictor model. And we make these assumptions to allow us to predict how drugs will interact within the body. But this doesn't account for certain parts of the ADME process, such as distribution and absorption. So although these mathematical models that we use, such as the single compartment model, which is where you inject the IV drug in, are useful for us to make predictions, it's good to be aware that it doesn't account for certain parts of pharmacokinetics. And so a drug might not necessarily act in the way we expect, and we need to consider that in dosage, essentially. And then the last two slides are essentially the two sort of major mathematical things we need to look into. So one being the therapeutic window. So could anyone have a go at describing the therapeutic window or what they understand it to be, please? Don't worry if you're not sure.
Would it be kind of the upper end of the therapeutic window is kind of where the drug becomes toxic,
Yeah.
and the lower end would be kind of where it's like clinically ineffective, so it's not reached kind of the half-life essentially.
Yeah, and your colleague has said a very, very similar thing. So I've just simplified this down in terms of this is probably sort of a calculation you'd want to make in your MCQ, so you don't need all the details. But as you very rightly said, you look at the LD50, which is the lethal dose of the drug for 50% of the population. Then you look at the EC50, which is the minimum effective dose for 50% of the population. So you divide the lethal dose by the effective dose, and that's your therapeutic window. And this is just important to consider in drugs where there is a small or narrow therapeutic window. So these drugs often require more frequent monitoring and account for periods of infection or dehydration where there might be an increase in the plasma concentration of these drugs, which can lead to toxicity. This is especially seen in lots of anti-epileptic drugs and drugs like lithium. So it's just a good thing to look out for and a good thing for us to be able to calculate. Lastly, plasma concentration. So these two graphs just show how the concentration changes between an IV bolus dose and an oral dose. And for the therapeutic window, as you said, the minimum toxic concentration, but minus the minimum effective concentration, is the range that we're aiming for. And the plasma concentration must be higher, obviously, than the minimum effective concentration. So that's a level, that's a point we're trying to hit. That is the end of my rapid fire presentation. There are some questions at the end within the feedback link, which also have answers. So if you could fill that out, that would be great. If you have any questions, please feel free to email me if it's about any of the things I've said within this, and I can send you my slides over or my notes over. And if you have any questions about the course in general, then feel free to email the general inquiry section. And thank you so much for coming.